All right, chapter 11, mental health. Mental health is a lifelong process, okay? Successful adjustment to changing environments. And many of us, mental health is everybody's issue, okay? But we know how to cope. We have great coping mechanisms, coping skills, support systems, etc. Okay, we know how to manage those things. But mental illness is defined by clinically significant behavior as a result of the client's distress or disability. And they have an inability to respond to the environment because of mental or medical conditions. Okay, they could be, they have an inability to relate to others based on their mood or how they're feeling, and daily functioning is impaired. Okay, could be impaired thinking, poor impulse control, or altered behavior. But in many clients, it's a temporary loss, while in others, it may be a lifelong series of intermittent exacerbations of illness. So, as the nurse, main thing we're looking at is nurse-client relationship. You want to build that relationship, and the goal of it is to facilitate quality client-centered care. Okay. So, again, you're going to leave all of your personal feelings outside of the door, and you're going to go in and care for that patient ethically and competently. Okay. You want to build trust. You want to provide privacy and confidentiality. Therapeutic communication, it works both ways. Like I've been telling y'all, 85% of that body language is communication, 85% of it, okay? You can say one thing, but your body language can convey something different. So again, you want to have appropriate, efficient, and flexible communication, okay? It's going to be based on the client's ability to provide feedback. So while you're listening, you're also asking open-ended questions so you can continue to gather history, information about your patient. But boundaries have to be established, okay, between the PN and the patient. So some principles, like I said, establish trust, have a non-judgmental attitude, offer self but be empathetic, offer empathy, not sympathy. Okay? Clarify and validate the client's statements. We want to use a matter-of-fact approach with mental health clients. Some examples of that therapeutic communication, like I said, open-ended questions, empathizing, silence while you're listening. But when you're sitting in silence and listening or quietly waiting, you have to have what? Eye contact with your client. Body is facing your client. So all that body language is telling them that you're ready to listen. Are you ready to receive what they have to say? Okay? That's one of the keys to building trust, is that body language. Okay? Examples of their other therapeutic communication. Active listening. Again, that's what I just described, giving your full attention to the client. Let's answer this question. Okay, correct answer is 4, okay? A social relationship with a former client is not appropriate, okay? So again, with mental health, you've got to use that empathy but not sympathy and use that matter-of-fact approach, okay? Coping and defense mechanisms. Patients use unconscious efforts to decrease anxiety. Like I said when I started this chapter off with you all. It can be constructive, okay, or it can be destructive. Coping is related to problem solving. So some defense is also related to protecting oneself, okay? So some not so good efforts on coping can be denial, displacement, and identification. We do have different types of treatment modalities. We have the MyLou therapy, we have collaborative care, interpersonal psychotherapy, that's where the person is understanding himself, behavioral therapy, cognitive crisis intervention, and ECT, electroconvulsive therapy. That might sound a little drastic, but that's used in the worst case scenario when all the medications have been used. MAOIs, SSNRIs, and they're not working for the patient. They will resort to ECT treatment. Okay? Let's answer this question. Bless you.
Thank you. Bless y'all too. What?
Okay, yeah. Don't change your answer. Go with your first one. Correct answer is 4, okay? Group therapy involves a therapist and 5 to 8 minutes. Provides feedback and support for individual goals of each member. When we're talking about group therapy, it could be for stress management, it could be self-care, it could be medication education, dual diagnosis, or cognitive behavioral therapy. Interpersonal group therapy, self-help, or support groups, or family therapy. Usually when family therapy is done and there's a change in one member, it'll bring about a change in the other members of the family. Now, with group therapy, installation of hope and optimism, okay? There's universality because they start to feel like, okay, they're listening to other group members. Oh, well, that happens to you. Okay, that happens to me too. They start feeling like they're not alone, okay? And that's universality. When they're imparting of information, they receive formal teaching by the leader or advice from their peers. There seems to be a cohesiveness. There's altruism. That's rewarded from giving support to others. That's what altruism means. Okay? They feel good that they're able to do something positive to support others. Okay? When they're communicating in the groups. Recapitulation. Feedback from the leader and peers. It provides opportunity to learn about dysfunctional, repetitive behavior. That's what recapitulation means. Okay? They're talking about things, they're expressing things, then they get feedback from the leader as well as the group. Then they find out, okay, maybe these behaviors I thought were normal for me to do and I've seen in my family, maybe they're not so normal, so they're learning. Okay? Development of socializing techniques, learn new social skills based on feedback from others, imitative behavior. They copy the positive behaviors they see in the leader or peers and can adopt healthier habits. Interpersonal learning, they give insight into themselves. Group cohesiveness, again, accept positive feedback and accept constructive criticism. Catharsis is intense feelings as they're being judged by the member or shared. Okay? So, intense feelings as judged by the member or shared in the group. And then existential resolution, they learn to accept painful aspects of life, whether it's loneliness, death, and they understand that these things affect everyone. Stages of group development. You have the initial stage, superficial communication. You also have the working stage. You have trust is established. The real work is done by the group. Okay? And then there's the termination stage. They learn how to deal with letting go. Let's answer this question. Own your knowledge, own your knowledge. I tell y'all have moved down on me. This is the last chapter. Own your knowledge, okay? Don't second guess yourself. I want to see more hands, numbers, fingers. Thank you all, those that have continued throughout. I appreciate you, okay? Yes, one. Okay, that's correct. Don't second guess yourself. When you read that question and read the stem of that question, ask yourself, what is this question asking me? And then you go through those answer choices, pick the best answer choice or choices. Okay? Now, anxiety. There's mild tension of just everyday life. Okay? Traffic, nursing school, okay? Mild, that's mild. Okay? Now there's moderate. There's some immediate concerns. There might be something that is pressing, gotta be taken care of. Okay? That's moderate anxiety. Then you have severe. Severe anxiety is just a fear of impending doom. Something's bad gonna happen. I know it. I know it is. Things never work out. Something bad is coming. Okay? You might know individuals that are that way. Okay? Now, this can lead to depression, helplessness, hopelessness, and panic states. And you don't want that. Okay? You don't want that for your patient. Okay? You're in a group setting, you're talking, you're going to be assessing, and you might see one of the members getting to that point where they're in this severe anxiety. Okay? And you're the nurse taking care of that patient. All right? Now, in the group setting, you might ask some open-ended questions. Or guess what? In a group setting, one of the other members might point it out. Okay? So that's when you're going to start using those therapeutic techniques and asking those open-ended questions. Because if it happens there in a group and you can see it, it can be addressed and worked on right there. Okay? Now, panic and terror. Arachnophobia, some of those phobias, we'll get to those in a few minutes. Okay? Disasters, natural disasters, a hurricane is coming, you know, you can get to that terror state of panic. Okay? Now, when we're talking about panic disorder, sudden feelings of intense apprehension with fear or worry. I gave you an example. Okay? Phobias, arachnophobia, it's a type of anxiety disorder. Agoraphobia, can anybody name any other ones?
So people are afraid to go outside. Is that a good thing?
It's one of them. Not sure which one. There's hydrophobia. In water. Okay. So you want to know the phobia. And again, the way that you take care of your patient and treat your patient, you want to reduce environmental stimuli, provide a calm, quiet environment, and administer the anti-anxiety medication if they're in that phobia state. Okay? Let's answer this question. them to finish that whole sentence. Let's answer this question. Correct answer is 3. Accompany the client to apply in here. Now, medications become anxiolytics, right? Benzodiazepines, they are very addictive, but they work really well. That's why they're only used for a short term, okay? Now, they have an anxiety reducing property, but they have a sedative, hypnotic type effect, okay? Flumazenil, also known as Romazicon, is the antidote for benzodiazepine overdose. You want to know that, okay? Somatic symptom disorders, DSM-5 disorders, okay? Persistent worry or statements regarding physical illness without physical signs. Types of somatic symptom disorders, you have illness, anxiety disorder, or somatic disorder, okay? Fictitious disorders like self-imposed or fabricated symptoms like Munchausen syndrome. And then you have Munchausen's by proxy, okay? I'm sure if you know about the story of Gypsy Rose.
Oh, that's hard to remember this.
Munchausen's by proxy, okay?
Is that the one with the-
extreme case.
Is that the one with the mom giving the baby salt water or something?
No, worse.
The mother predisposed the child to illnesses throughout her life.
She died in her first daughter. That wasn't really bad.
Yeah. So it's Munchausen's by proxy. It wasn't her illness that she had predisposed fictitious illnesses on her child.
What was the name of the child?
Gypsy
She
Rose.
wrote Blanchard. She's already.
She a celebrity now.
For real.
Never even
So
heard of it.
annoying.
You ain't watching the show.
What show?
Okay.
You'll never forget Munchausen's by proxy
Well,
ever.
I've never heard of this person in my life.
yeah.
Gypsy Rose.
So with crisis intervention,
She has a cute name.
you want to know what is the crisis state. It's usually going to stem from a significant traumatic event, okay, or a situation that cannot be remedied using the client's available resources or coping strategies. So, risk factors for crisis states: multiple comorbidities or losses for the client, unexpected life changes, limited coping skills, chronic pain or disability, poor social support, limited access to healthcare services, concurrent psychiatric disorders, substance abuse, or disability. Okay? The goal is to return the client to pre-crisis level of functioning. Okay? Nursing and collaborative management, you want to assess this for suicidal or homicidal ideation. Active listening helps the client feel safe and less anxious. So be directive, okay? If you need to, I keep saying, if you need to incorporate those interdisciplinaries, you want to contact social workers or case managers that can help you get the patient maybe into a shelter if they need it, get housing, and mobilize their social support. So ask those questions. Do they have maybe a pastor or clergy at church? Okay. Support groups throughout if they belong to a church. Okay. Involve the client in identifying realistic, acceptable interventions, and regular follow-up is generally not planned. When we look at post-traumatic stress disorder, or PTSD. Okay? We read it. Huh? You said what? Not this one? What'd you say? No? You weren't talking to me.
Who, which one?
Yeah. Oh, okay. I thought you were. So, they re-experience these events just like they're actually happening to them all over again. Okay? It could be dreams. It could be a flashback. It could be associated with clusters. They can smell a smell. Okay? So they use extreme measures to avoid reminders. Okay? Symptoms of numbing. Some of those can be good. Some can be bad. Some types of numbing can be with drugs or alcohol. Okay? And then there are alterations in behavior, including self-destructive behavior like suicide. Okay? That's an extreme. But those thoughts can be persistent. Okay? And they can alter mood and cognition. Now, a continuation of stress and anxiety, we look at others like intrusive thoughts, nightmares, emotional detachment, and flashbacks. Okay? Because you could be going along about your day, having a great day, and then you get that flashback of something that happened that was a traumatic event or stressful. Okay? So, again, like I said, reactions can be triggered by physical reminders. Okay? There could be a physical disability that the patient might have. That's a consistent reminder. Okay? So responses include shock, anger, denial, panic, self-destructive behavior. Okay? Like I said, it can also be substance abuse or suicidal ideation. So as I'm telling you all these things that could be happening with your patient, and you're the healthcare provider, safety is always going to be key, okay? Safety is always going to be key. Be mindful of your personal space. Your personal space is an arm's length all the way around you, and your patient's personal space is the same, okay? Never back yourself into a room, into a corner. Be sure you're the one by the exit. Okay. So you want to assist your client in identifying past successes. Okay. You want to give them something else to think about when they've been successful at something or accomplished something. Okay. That helps them what? Regain control. Okay. An unconscious defense mechanism that protects the person against overwhelming anxiety. These are called dissociative disorders. Dissociative amnesia. They can't recall one or more episodes of something. Usually it's due to a trauma. Okay? Dissociative identity disorder. That's like the split personalities. They have two or more distinct identities. At least two of them recurrently take control. Okay? When the individual feels threatened. There's also depersonalization or derealization disorder. There's persistent or recurrent episodes of feeling of detachment from oneself. And then you have the personality disorders. Obsessive compulsive disorder, antisocial personality disorder. Okay? We kind of talked about OCD a little earlier with the question with the hand washing. Okay? Borderline personality disorder, highly changeable individuals, okay, with an intense affect, poor impulse control, and always pits perceived good person against perceived bad person. Okay. And then there's the associative behaviors. You have inflexible maladaptive behavior patterns. They're in touch with reality, but they lack insight into their own behavior. There's poor impulse control, and the forms of acting out associated with this behavior can be like yelling and swearing all the time, cutting their own skin, manipulative behaviors, manipulating others, abusing substances, promiscuity, and attempting suicide. Let's answer this question. Correct answer. It is correct, matter of fact. Now, when we look at the eating disorders, and I want you to look at the picture on 139, okay? Bulimia versus anorexia, okay? Anorexia is often associated with a stressful event, but death can occur from starvation. Everyone will starve themselves to death or commit suicide, okay? They might have cardiomyopathies or electrolyte imbalance. Okay? They have an altered body image. So with anorexia, this is what their body would look like. You can see the ribs, you can see the clavicle. They're starving themselves to death. Okay? But they don't see it. We see it physically for what it is, but their body image, when they see themselves, looks like something totally different. Okay? Now, with bulimia, that's binging and purging syndrome. Okay? If they'll binge on food, then they'll purge. What are some ways of purging other than making yourself vomit?
Diarrhea. Laxatives.
Well, that'll make them vomit, but max citrate. Okay, extreme laxative. Okay, not just my laxative.
A lot of energy drinks.
Flush it out. Okay, because they can eat all the food and they want to flush it.
Wait, so you can eat a lot of food and then drink a bunch of energy drinks and then.
Not energy drinks. No.
Oh.
He said energy drinks.
Oh, okay.
I said magnesium citrate. You know, like that you can drink. Okay, it's like a laxative. Okay.
It is a laxative.
And it washes it straight out. And think about what we said about diarrhea. What does that do to electrolytes? Yeah, make you get rid of it up. Okay. So again, binging, purge means to get it all out of your system. So they're eating, and then they're purging. Either they make themselves throw up or take lots of laxatives. Right? Now, compulsive overeating. Binge-like overeating without purging. They just have a lack of control over food consumption. Let's answer this question.
Jesus.
Correct answer is 3. You want to check those potassium calcium levels out to see if they're already too low for treatment. A client diagnosed with bulimia is admitted to the mental health unit. Which intervention would the PN implement first? So an intervention is to obtain serum and potassium levels, calcium levels. Because we know that they have bulimia already, okay? We want to see where they are at this point. Because they might be so low that we might not have to do an intervention immediately, okay? Now, going back to what Travis said about patients with anorexia, now, they do have a tendency to just over-exercise, okay? And when they get tired and can't hardly go anymore, they will drink tons of energy drinks so that they can keep going, keep running on that treadmill, or keep, exercising, yes, to make themselves look good. Okay? Now, depressive disorders are characterized by feelings of hopelessness, low self-esteem, and a tendency to blame self for every negative event. 25% of those with depressive disorder have suicidal ideation. So when you're doing your assessment, you have to ask the question, do you have any plans on harming yourself or others? And if so, what is your plan? Okay.
What is your plan?
Behavioral therapy, CBT, and interpersonal psychotherapy to reduce those symptoms of
Yeah, my damn
depression.
time.
Of depression. But if that doesn't work, antidepressants are also used in conjunction. So we do have the SNRIs, the SSRIs, and the TCAs. Okay? I want you all to know that the first dose takes, and the first dose or to get the treatment going, or take it in their system, they'll take their meds every day, but it takes 2 to 4 weeks before it even does anything for they can feel it. Okay? Having said that, if the doctor changes those medicines and moves them to an MAOI, they have a 2-week washout period where they can't take anything before they start the next med. And then when they start the next med, it's 2 to 4 weeks before it'll start working. Okay? So as you can imagine, what can happen in between time? Huh?
Probably mix it.
No, they don't have anything on board really. The deeper depression and suicidal ideations. So with some of these medications, hypertensive crisis leading to possible symptoms of hypotension, coma, or seizures may occur with concurrent use. So while they're taking MAOIs, and I'm sure you'll all probably have seen the commercials about some of these, they say, why are you taking this med? You cannot take it. And they list a whole list of stuff. Okay? Well, this is one of those lists. Okay? MAOIs, you can't take decongestants, amphetamines, antidepressants, dopamine, opioids, epinephrine, guanidine. You can't take that. You can't take levodopa, methyl-dopa. You can't have nasal norepinephrine. You can't take reserpine, vasoconstrictors. You can't take any foods that contain tyramine, and those foods are red wine, aged cheese, and raisins. Okay? So again, it's like, wow. Now, high alert antidepressant use, hyperthermia, rigidity, cognitive impairments, and autonomic symptoms can occur. They're potentially fatal, okay? And it can occur at any time. That's a side effect, anytime during this therapy, okay? So when you're talking to this patient and you're telling them all these things, it kind of can set in fear, okay, of not wanting to take it, not wanting to start it. But you want to explain the benefit versus the risk, okay? There is something called antidepressant apathy. Some clients lose interest in life and events around them related to SSRIs. There's antidepressant withdrawal syndrome if they abruptly stop them, okay? That can trigger withdrawal symptoms. There's antidepressant loss of effectiveness if they've been taking them too long, maybe they just don't work anymore. And then there's antidepressant-induced suicide, and that's seen in a high group of young people ages 18 to 24. Like when we talk about suicide, a suicide threat is a warning, direct or indirect, verbal or nonverbal, that a person is planning on taking his or her own life. When they start giving away their prized possessions, they're all of a sudden happy. They might make funeral arrangements, okay? You want to ask those questions that I just told you about. Do you have a plan on harming yourself or someone else? If so, what is your plan? Okay. You want to give them, put them on suicide precaution, suicide watch, give them a one-on-one sitter. You're going to check them, check for anything they could use to harm themselves, okay? But never leave a suicidal client alone. With bipolar disorder, it's characterized by alternating episodes of mania and depression, between which the client has periods of normal mood and activity, okay? Now, we do give mood stabilizers, and lithium is the drug of choice, but they need to continue to see their doctor and get their lithium levels checked, okay? Due to lithium toxicity. Toxic level is greater than 2 of lithium, okay? There are other medications that are given. Divalproex, olanzapine, and carbamazepine are also given to treat bipolar disorder, okay? Now, lithium toxicity, the normal range, and remember, your exam will give you these normal ranges, okay, for labs. Lithium but you have to know what to do with it. Lithium ranges from 0.8 to 1.2, okay? Expected side effects are the hand tremors, polyuria, mild thirst, weight gain, and mild nausea. But starting signs of lithium toxicity can start as early as 1.5, okay? Then you'll start seeing nausea, vomiting, diarrhea, slurred speech, muscle weakness. You want to withhold the medication. You'll tell the doctor that you're holding the medicine, obtain a lithium blood level, and notify the Army. Okay? So advanced toxicity is coarse hand tremor, persistent GI upset, mental confusion, muscle hyper irritability, and severe toxicity is ataxia, seizure, hypotension, and even death. Let's answer this question. Withhold the dose and notify the care provider. When we look at schizophrenia spectrum or other psychotic disorders, the difference with schizophrenia, their positive symptoms and their negative symptoms, okay? I want you to remember it this way. The positive symptoms of schizophrenia are like illusions, hallucinations. It's adding something, okay? Adding something. Hallucinations, illusions, delusions. The negative symptoms are taking away. They're flat affect, poverty of speech, depression, sluggish, movement disorders. It's negative, it's like taking something away, okay? I want you to remember it like that. Now, safety is a priority, and you want to assess for the risk of violence with schizophrenic patients, okay? Like I just explained, those safety measures you can do, your personal space, not getting cornered, staying by an exit. You want to establish routine, use empathy, not sympathy, and set boundaries with this schizophrenic patient. Set boundaries, okay? Encourage reality-based interests. Antipsychotic medications, you'll see some of them here. Just gonna list a few. Traditional meds are like Haldol. Okay. You also have medications that treat psychotic behavior side effects. Okay. You also have medications that are long-acting, like clozapine, Risperdal. Okay, they're long-acting medications. And then side effects to those can be neuroleptic malignant syndrome, where a patient gets very high fever. Okay. So you want to teach your patient when they're taking these medications, change positions slowly, okay, to prevent dizziness. Report any urine retention. Stress the importance of maintaining medication therapy. Okay. And then atypical medications are medications like Abilify. And they treat all the positive and negative symptoms of schizophrenia. Okay. but side effects, multiple side effects depending on the medication. Now, this neuroleptic malignant syndrome, it involves autonomic motor and behavioral symptoms, and it happens to the patient when they abruptly stop their antipsychotics. Okay? They get severe muscle rigidity. Their temp can go up as high as 104, increased pulse, level blood pressure, confusion, autonomic dysfunction, agitation, and it involves autonomic motor and behavioral symptoms. So just a couple of the medications I'm going to tell you. Haloperidol can cause this. Okay. Amantadine can cause this. Lithium can cause this. And then opioid abuse. Signs and symptoms: poor coordination, drowsiness, shallow or slow breathing rate, nausea, vomiting, to name a few, irritability, euphoria, depression, anxiety attacks. And remember that the antidote is naloxone. Now, with alcohol abuse, I want you to understand that alcohol is a central nervous system depressant. So, patients can have a physical dependence. Okay, when I talk about physical dependence, there's a biological need for alcohol, okay, to avoid those withdrawal symptoms. Psychological dependence, they have that craving for it. And then intoxication is a blood level of 0.1%. That is 100 milligrams of alcohol per deciliter of blood, okay? Antabuse is a medication we give patients that abuse alcohol. Now they agree to take it because they want to stop using alcohol. The side effects to that, if they come in contact with anything with alcohol in it, they will get nauseous and start vomiting. Okay. Severe GI upset, nausea and antabuse. Okay, so they can't even have cough medicines with alcohol in it, mouthwashes with alcohol in it, and aftershave lotions with alcohol in it, just applying it to their skin. Okay. So there are a couple of other medicines that help assist with craving, but they're not as severe as or as in your face as antabuse. Okay. It's naltrexone is one of those medications, and acamprosate calcium is another one of those medications. You want to know about alcohol withdrawal, okay? So at the time of admission, you want to ask the client, when did you have your last drink? That withdrawal is going to peak after 24 to 48 hours, okay? We do give Librium for the withdrawal. The withdrawal delirium peaks within 48 to 72 hours and can last 2 to 3 days, and it is a medical emergency. You need to notify the RN. Death can occur from the withdrawal delirium. Let's answer this question.
So we're looking for DCs then, is that what it is?
You got to determine the time and amount of the quantum of alcohol intake. It's the most important thing that the clinician. Autism spectrum disorder, neurocognitive disorders. With autism, it is a group of developmental disorders that includes autism, Asperger's disorder, okay? And there's no known cause, but clinical description is hyperactivity, short attention span, impulsivity, aggressive behavior, okay? Self-injurious behavior, temper tantrums, preoccupation with objects or spoken language something absent. But the hallmark symptom of the autism spectrum, the patient has an islands of genius. Okay? What I mean by that is there's one thing they can do absolutely perfect. There's an old movie called Rain Man, if you've ever seen it.
Judge Lum.
His brother was a genius for numbers. Okay? Then recently on social media, there was a young man that was autistic that flew over the New York skyline. I saw that, and he drew the picture verbatim of this Mobius when they were flying. Okay? So that's what an islands of genius is. Attention deficit disorder, ADHD. No known cause and strong correlation between genetic factors. Clinical description, does not follow rules, loses train of thought, loud and disruptive play, getting up when expected to be seated, excessive running, fidgeting in their seat. With adult ADHD, many adults say that they lose the hyperactivity portion in adulthood, but continue to have difficulty concentrating and attending complex projects. Now, other neurocognitive disorders that are not classified as mental illness, we have major and mild neurocognitive disorders. So primarily, acquired cognitive symptoms that represent a decline, okay? So we look at these, and usually they are caused by traumatic brain injuries or HIV. Now, and again, they're not caused by mental disorder. Then there are mild ones, okay? It does not interfere with their independence, and it's not due to delirium, okay? But they do have impaired judgment and abstract thinking. Cognitive domains that they typically have problems in could be learning and memory, language, perceptual, motor, social cognition, executive function, and complex attention. When we look at dementia, it's a progressive deterioration in intellectual function. It's secondary to structural or functional changes in the brain. Okay? Now, dementia is not classified as a DSM-5. Okay? So it's not really classified as a DSM-5, as mental illness. But they lose long-term and short-term memory, impairment in judgment and abstract thinking and problem solving, okay? And it's caused by nerve cell deterioration. So again, safety in the environment. You don't want them walking off and getting lost, okay? Slipping and falling, etc. Alzheimer's disease, it's irreversible, okay? It's a form of senile dementia, and it's caused by nerve cell deterioration. So again, safety is key. You want to maintain comfort, toilet them as necessary, keep them dry. And have a routine. In the morning, open the curtains, help them with their activities of daily living, brushing teeth, hair, sitting down and have breakfast, okay? You want to keep their day going and give them a routine. In the evening, close the drapes, help them get ready for bed, maybe some soft music, okay? Provide a nightlight. Give them reassurance and companionship. But it's very important that you encourage the family members to be a part of it. So they can be there, somebody they know, okay? Might look familiar, they might not know them some days, okay? But family support is key. Other neurocognitive medications that can be used are Donepezil, which is also known as Aricept, galantamine, memantine, rivastigmine, and tacrine. Okay? Tacrine is another medication that can be used for Alzheimer's. Let's answer this question. 21-year-old with a diagnosis of schizophrenia, the paranoid type. Highlight in the history the negative symptoms of schizophrenia the client is experiencing. Okay, that's where you want to start?
Grades begin to climb.
Grades begin to decline.
Become
He's
withdrawn.
skipping classes, he's become withdrawn. Spend most of his time alone.
And then he has deterioration.
2 days, he was, oh,
So basically that
So,
whole thing.
yeah, that whole section right there, okay? So remember those, the filters between the negative and the positive symptoms of schizophrenia.